Hello again. Going to talk about strep throat today. So let me get this going. Okay. So let's start a little bit about the bacteria that causes strep throat. It's called Streptococcus group A. And if you look up at the right picture, this is under microscopy and gram stained. And this is a good example of the linear look of this. This is all bundled up here. But literally, it's like a chain of berries if you ever do gram staining with microscopy. So a couple things, it does live naturally on our body in the throat, lives around the genitalia. If you see this picture here down where the pointer is, obviously this is some pus, exudate as we call it in medicine, and swollen tonsils here indicating a strep throat infection. Looks very painful, probably difficult to swallow. Sometimes even just swallowing saliva can be painful where people actually start drooling a little bit so they can prevent swallowing. But the other thing that we see with the strep group A, the bacteria, is impetigo. So if you see this little child here, we would describe this as honey-colored crusts. And this is actually the bacteria literally kind of breaking down the skin, and can be painful or itchy. If allowed to grow, it actually can damage the epidermis and leave scarring on the face, essentially. So, too far. So here we go. So what are some signs and symptoms of strep throat? So in medicine, I have memorized the CAFE acronym to help me. Basically, what that stands for is cough, adenopathy, fever, and exudate, so CAFE. And if you have a positive cough, it's probably not strep throat. It's probably viral. And the coryza part of it is basically conjunctivitis, runny nose, a cough. That would indicate more a viral upper respiratory infection. Positive signs are going to be the adenopathy. So if you look over here to the right, we have a swollen lymph node in the cervical area. So that could be positive. And that just indicates the body's lymph system fighting off the bacteria within the circulation there. And usually a little bit of fever can be very mild in adults, but it's usually present. And then when you actually do your throat exam, you're going to see the pus, the exudate from the bacteria and the immune cells kind of fighting. So if you look here in the center, we see some pattern of exudate on both tonsils, some erythema, very red, and this is probably very sore, trouble swallowing. The adenopathy part, you may not have that present on your patients, but as part of the exam, you always want to look at the cervical nodes here. Kind of feeds the back of the mouth and throat, and a lot of times they do get swollen and tender acutely. So essentially, if you can remember the CAFE acronym, that cough, negative, adenopathy positive, fever positive, exudate positive, if you have two or more, you're going to go ahead and diagnose this by swabbing, essentially is what we're doing. It's a very rapid antigen test. Looking for a positive exam, and if negative, then we need to lean towards, is this a viral or something not strep bacteria related? A lot of times mono Epstein-Barr or cytomegalovirus virus can kind of get in there and kind of duplicate some of those symptoms. I put this down here to show you what that coryza part of it is, that conjunctivitis, that red itchy eyes, would not be associated with strep. Sneezing, congestion, runny nose, not associated with strep. Itchy coughing is from a postnasal drip is not associated with strep. So those are important things to keep in mind. So we talked a little bit about the diagnosis. See this little girl getting swabbed, and that's how we typically do it, especially in family practice. It's a rapid antigen test. It's pretty specific. It has a pretty specific, this is from up to date here, as high as 95%. It is a little, or for specificity, sensitivity can be lower. You can get false negatives, but generally it can help guide treatment. And obviously as a clinician, you have to use your gestalt to determine, like, If I have a false negative, but everything is looking like strep throat, you have to make a clinical decision on that. You can follow up and do a monospot test. I put a little diagram or a little picture showing the monospot, which is also a rapid antigen test that you can do. You can also send for blood work and check Epstein-Barr virus patterns, and you can actually check strep in the blood as ASO, although it might not be positive if it's early. The alternative diagnoses that we have to keep in mind on top of strep is, like we talked about, that mono, which is a virus that's common in younger people sharing drinks, things like that. Cytomegalovirus and other cold viruses can cause the coryza symptoms that we don't normally see in strep. So that should be kind of in the back of the mind. Other things, gonorrhea, chlamydia can occur. Those are bacteria from sexually transmitted diseases that you can get from oral sex even, that can infect the back of the mouth. You can always test for those things. Usually mycoplasma bacteria, which cause pneumonia, that the atypical bacteria that we talk about in pneumonia, but that's going to be more for like bronchitis. And if it's early, I suspect it could cause some of that pharyngitis in the back of the throat before it works itself down. And then something I have seen quite often is herpangina, which is literally ulcerations around the tonsils. But if you look at the difference, I went back here on the exudate and then compare it to these little ulcers at the back of the throat. You see the tonsils aren't quite as swollen, and there's no exudate there from white blood cells being killed and fighting the bacteria. And this can be quite painful, but it's basically symptom treatment for that. So how do we treat strep throat? Essentially, always antibiotics. And the reason is there's a lot of potential complications without this. In the old days before I was practicing, I've heard from some older physicians talk about some of the things we'll discuss, complications of not treating with antibiotics, people not seeing the doctor in time and developing acute rheumatic fever, rashes, scarlatina, and even glomerulonephritis, which is an infection, essentially the toxins injuring the kidneys. So our go-to is penicillin V, and it's still effective for strep. I've heard people say in medicine, I don't know why the family physician gave penicillin V for this. It is considered first-line treatment if you don't have a penicillin allergy. You can use amoxicillin. It's in the same family. Penicillin V is a little cheaper, and it is effective against strep throat. If we have a penicillin allergy, and it's mild, meaning there's no swelling, major hives type reaction, it's just a minor like skin itching maybe, we can go ahead and use cephalosporin like Keflex. Just be careful with that you know what you're doing. If there's a severe penicillin reaction, like the hives, swelling, itchy throat, trouble breathing, we're going to go away from all the cephalosporins and penicillins and go with something like azithromycin. You can also use clindamycin, although clindamycin has a little higher issues, complications, but it is effective. Some regions, as strep throat, the pyogens is resistant to azithromycin. So we kind of need to know our local antibiotic resistant patterns and to make that decision. So here's the thing, if we miss it, I'm just going to cover two. There's a whole host of things that complications from the bacteria itself or the toxin byproducts. One is scarlet fever. And this was apparently quite common. I've had told to me by some old-time physicians, for kids that would show up, they tried to push through the strep throat, the parents for whatever reason, and they end up with this strawberry tongue and diffuse scarlet rash. I tried to find some pretty extreme examples of this, and you can see this. The tongue here looks like a strawberry. And this rash has been described as sandpaper. So it's little tiny macules all over. And when you rub your hand, it feels literally like a sandpaper, like a fine grit sandpaper on the skin. This is the result of the toxin byproduct of the strep. And the way that we treat this is essentially the same way that we treat the strep. Another missed thing that can be even more severe, and this is the one that gets the mitral valve we hear a lot about in medicine, cardiac valve issues, is this acute rheumatic fever. So there's a delay. So strep throat you can get over it without antibiotics, but if the toxins and the bacteria get in the bloodstream and circulate, you got bigger issues. So the one thing that I memorized from going to school is the Jones criteria. So JONES, and essentially it's just an acronym to help you remember some of the symptoms. The J is for joints. There will be a diffuse joint. It can be symmetrical, can be asymmetrical, but most kids don't complain about joint pain unless there's something going on. The O is kind of like the shape of a heart, and we have to worry about that pericarditis, the mitral valve injuries. That's actually diagnosed, obviously, with stethoscope. If it's severe, you'll hear a murmur, but echocardiogram to take a better look. There will be some subcutaneous nodules, so the N's for nodules. So I got a picture here. These little subcutaneous nodules, they don't have to be on the elbows. They can be on other joints. The erythema marginatum. So this is a picture. So you can see the margins of this is very discrete, and that's one of the signs. And then the chorea, the Sydenham chorea. And what chorea basically means is flowing movements, jerking movements. And there will be this restlessness if it's in children. They'll be clumsy, falling, moving, can't sit still kind of thing. And so these are just some of the symptoms that can help you diagnose. It's called the Jones Major criteria. How we diagnose this, obviously clinical, you're going to start to, if you suspect and there was a history of a sore throat leading to some of these symptoms, then we should heavily suspect strep throat and treat. But the way to diagnose this is with the blood test ASO, and basically with the ASO, we're checking for previous sensitization exposure in the bloodstream to strep. And it will be positive if they've had a recent strep throat in the last month or so. Same thing, what are we gonna do with this? We're gonna treat it just like strep. I tend to feel like giving that first dose in the office of the penicillin G, IM form if available, and then finishing up with orals is a good way, just because we got here from not treating the strep. I feel heavily in family practice to give something that you're going to put in there, like an IM shot of penicillin if you carry it, so that the patient and the family leaving there will have something on board if they don't run out and start the oral antibiotics that soon. So that's it. That's what I just had a few things I wanted to talk about. I just want to say it's pretty rare these days to see the scarlatina because we're so aggressive with the pharyngitis, the strep pharyngitis, to give the antibiotics. I haven't seen this a whole lot. I have seen it once or twice, but some of the people that have trained me who've been in medicine for a very long time have seen this, and that's exactly how they kind of that scarlatina, that strawberry tongue, and that sandpapery rash. I did not talk about glomerulonephritis, which is an injury to the glomeruli of the kidneys. Symptoms of that would be Coca-Cola urine from the bleeding, hypertension, so sudden hypertension, and a loss of urine would be an extreme case of glomerulonephritis. But the bacteria, if not treated, and the toxins can cause some of that. If you have any questions, feel free to reach out to me in the comments. I'll do my best to respond to them. Thank you very much.